We'll be speaking on excision of ganglion and the surgical tips. Ganglion being the most common soft tissue tumors of the hand. These are mucin-filled cysts. Patients usually present with symptoms of cosmetic appearance of the mass, pain, and weakness. And many a times, patients usually have concern about potential malignancy source. In 10% of the cases, there is minor injury associated. There is no occupational correlation though. And if this swelling is improperly excised, 50% of the cases do recur. How do we diagnose this? Standard X-rays are usually inconclusive. Wrist arthrogram has been described to reveal the cyst, and this postulate of one-way valvular mechanism can be evident on the wrist arthrogram. But often overlooked and most important diagnostic tool is ultrasound. The importance being dynamic and it is cost effective, especially in volar wrist ganglion or flexor sheath ganglion and first extensor compartment ganglions. The ultrasound is of great help because of the critical adjacent structures to it. As far as the management goes and coming to the surgical management, non-operative management aspiration is 20 to 30% effective in the long term in certain studies. But assurance to the patient that this swelling might resolve on its own is the most important non-operative treatment. As far as operative treatment goes, persistently symptomatic ganglion is the commonest indication, and the principles being to minimize the scar formation and the loss of range of motion. Open versus arthroscopic excision has shown equivalent outcome as shown in these studies in American Hand Surgery journals. Now, ganglion in the hand and wrist have multiple sites, but the enumerated ones are the commonest to see. Dorsal and the volar aspect, dorsal being the commonest, and this retinacular ganglion, one on the flexor tendon sheath and one on the first extensor compartment, which I am pointing out over here. These are also usually very well seen. Coming to the commonest type of the wrist ganglion, that's dorsal. It arises from the scapholunate ligament and extend via long pedicle anywhere through the extensor tendons, which I'm showing it here in the pictorial presentation. And this possibility of recurrence is mainly due to failure of excision of this pedicle only. It is very rare in other carpal joints. Surgical management wise, transverse incision over the proximal carpal row and the plane between EPL and EDC is to be looked for. The wrist in volar flexion, the joint capsule is opened along the border of the distal radius and scaphoid's proximal pole. Capsule is elevated and retracted distally. The capsular incision around the ganglion is continued, but the SL attachment should remain intact. Ganglion and its capsular attachments excise tangentially of the scapholunate ligament, and the intact scapholunate ligament should be seen well. The excised joint capsule should be around 1 to 1.5 centimeters, but the critical point here is not to curate out the scapholunate interosseous ligament. Here is an illustrative case here, the dorsal wrist ganglion. It's multiroculated, coming out from the extensor compartment. And here it is a stalk which is going into the scapholunate joint. As far as post-operative care goes, wrist splinting in slight volar flexion, early range of motion, and physical therapy as necessary to avoid wrist stiffness. Early range of motion in hand and fingers is very crucial. Scar therapy to prevent any scar issues. Coming to the second most common site, volar wrist ganglion, the commonest sites being distal edge of the radius and scaphoid tubercle. It is usually multiloculated. Extensive dissection will be necessary due to extensions. And the critical point here is Allen test, to see the dominance of the dominant vasculature in the hand, whether it's radial or ulnar. In the volar wrist ganglion, the commonest site is on the radial side, and you can see it here. The cyst is coming out of the radial artery bifurcation. Now, here is an illustrative case which I did with Dr. Bipin. The swelling is seen over here. This is the marking here. X-rays are non-remarkable, and it is very adjacent to the radial artery between the FCR and the radial artery. As you see, the swelling is getting exposed here, and we are coming down to the stalk just at the bifurcation of the radial artery. After its excision, the bifurcation of the radial artery is well seen, and it is going down to the radiocarpal joint. Coming to the third common type of a volar retinacular flexor tendon sheath ganglion. It mimics trigger finger, It arises from the A1 pulley and is usually palpable at the MCPZ crease. Cyst is attached to the tendon sheath and it doesn't move along with the tendon. That is very important. Conservative attempts are must before advocating any surgery. Because surgery, there are the critical structures like both the neurovascular bundles are adjacent and those to be looked for. The last important type is dorsal retinicular ganglion. You can see a marking over here, and as you expose down, you can see a superficial radial nerve here. Superficial radial nerve can be seen, and the swelling is coming from beneath onto from the first excision compartment sheath. And after excision, you can see the first excision compartment being released and the superficial radial nerve well preserved. Principles being same, I just want to illustrate another case on the foot, whereas this swelling is arising from the Lisfranc joint. Swelling is getting evident over here, and you can see a nice stalk coming out from the Lisfranc ganglion. So unless you see this stalk or the pedicle arising from the joint, and you shave off this stalk and the capsule adjacent to it, you rest assured that you are not complete. And so take-home points will be: persistent symptomatic ganglions require intervention. Recurrence is usually due to inadequate pedicle excision and the inadequate capsular excision. The reappearance at the same site years later could be new and not the recurrence. Volar ganglions and the flexor sheath ganglions are notorious because of the critical adjacent structures, and hence loop magnification is although worthwhile in these particular swellings. Don't forget to send this specimen for the histopathology, and wrist stiffness can be prevented by early motion and physical therapy as necessary. I thank you all my co-faculty and online viewers for the kind attention. Thank you very much.